Evidence regarding thrombolytic therapy for childhood stroke. Class 3 recommendation. Until there are additional published safety and efficacy data, TPA is not recommended for AIS outside of a clinical trial. Remember, however, there is a class 2 recommendation supporting and considering thrombolytic therapy with TPA in a selected children with a venous stroke due to CVST. There is a more supporting evidence for intravenous thrombolysis in a venous ischemic stroke than arterial ischemic stroke in children. Evidence-based specific therapy for pediatric stroke. Class 1 recommendation, the individual with Fabry disease should receive alpha-galactosidase replacement therapy. In class 2 recommendation, seek and treat iron deficiency because it may increase risk of AIS in conjunction with other risk factors. Measure the serum homocysteine level of children with CVST and AIS and institute measure to lower the homocysteine level where it is higher than normal. Diet and supplementation of folate, vitamin B6 and vitamin B12 in this case during management. Hemorrhagic stroke. Approximately 50% of the childhood stroke are hemorrhagic origin in contrast to approximately 50% in adult. Hemorrhagic stroke are two types, intraparenchymal hemorrhage and subarachnoid hemorrhage. The major cause of hemorrhagic stroke is a vascular malformation which include arteriovenous malformation, aneurysm and cavernomas. Hence, look for any hemangioma and vascular and neurocutaneous marker on a general examination. Drug-induced hemorrhagic stroke, it is phenylpropanylamine, there is a nasal decongestant, cocaine and other illicit drugs they cause hemorrhagic stroke. And hypertension could be precipitating factor, rarely but not prominent as in adult in case of hemorrhagic stroke in children. Next, risk factor for hemorrhagic stroke. Intracranial vascular anomaly, 48%, there is AV malformation, cavernous malformation, and aneurysm. Hematological abnormality, there is 10 to 30%. And thrombocytopenia, hemophilia, von Willebrand disease, coagulopathy, secondary to the hepatic dysfunction or vitamin K deficiency, iatrogenic due to heparin and warfarin therapy. And 9% brain tumor, they also cause hemorrhagic stroke, and 19% stroke risk factor for the stroke in children. There is idiopathy, cause is not known. Next, clinical presentation of hemorrhagic stroke. In case of intraparenchymal hemorrhage, presented with seizures, vomiting, rarely developing focal neurological deficit, altered sensorium, rapid drop in conscious state from normal even to comatose state, and signs of raised ICT. In case of subarachnoid hemorrhage, presented with sudden catastrophic event that may be preceded by sentinel headache and severe first in lifetime worst headache followed by sudden onset vomiting and altered sensorium. So in case of subarachnoid hemorrhage, sentinel headache or worst, very painful headache, vomiting and altered level of consciousness, first time in life. Next, how to diagnose this stroke in children? A strong index of suspicion is required to make diagnosis of hemorrhagic stroke clinically. Spontaneous bleed in absence of coagulopathy is setting of AV malformation is challenging to diagnose at the time of first assessment, spontaneous bleeding. In an acute setting, CT brain is often investigation done first and will detect bleed in the majority of children, but etiological yield is low. CT scan of brain shows hyperdensity in a left intraparenchymal region suggestive of hemorrhagic stroke. Although conventionally, many think MRI brain detection rate to pick up bleed is poor as compared to CT brain. And the role of susceptibility with imaging sequence of MRI brain has changed the dynamic and promising option to detect hemorrhagic stroke. Next, CT brain with CT angiography along with MRI brain, including sequencing, is often neuroimaging of choice in a child with suspected hemorrhagic stroke. Digital subtraction angiography is done in advanced center and its diagnostic yield is excellent. There is no clear-cut consensus regarding exact timing of this stage in any standard guideline, and decision is often clinical based on feasibility. Next. What is the treatment of hemorrhagic stroke? Immediate stabilization and supportive care as mentioned in arterial ischemic stroke. Administering vitamin K, fresh frozen plasma, recombinant clotting factor therapy depending on the scenario, and neuroradiological intervention, surgical repair of AV malformation and aneurysm. So today's pediatric stroke, my key messages are consider stroke in any child presented with acute onset of hemiparesis or focal deficit and change in mental status, headache, seizures with speech disturbance. MRI brain with MRA is an investigation of choice, but it is recommended at least that CT brain is performed within 1 hour of arrival at hospital in every child. And ME venography is done if cerebral venous sinus thrombosis is suspected. Aspirin has to be started in all cases of arterial ischemic stroke as soon as possible in absence of contraindication except arterial dissection, cardioembolic stroke, and hypercoagulable state. In CVST as well as arterial ischemic stroke caused by arterial dissection, cardioembolic stroke, or hypercoagulable state, anticoagulation using low molecular weight heparin, there is enoxaparin and unfractioned heparin or oral warfarin is used. Next. Role of thrombolysis in pediatric age group is controversial. However, there is a growing evidence and looks promising. Thank you.